Um, Hi, everybody. Thank you so much to those of you who are joining us directly now on the session. And for those of you who maybe will watch later or will um, watch it at another point, you're more than welcome to send me questions if you think of some later. And for those of you who are joining now live, as always, if you need to just stop me in the chat, or you can, physically just put up your hand and ask a question. It's really not a problem. So today we're going to talk about an emergency procedure that's quite common, which is ring removal. And, the thing is, rings are quite commonly involved in problems that we see in the A&E. And it's one of those where you get the patient, at least an hour or 2 hours of your time is gone, because some of these can take quite some time to come out. Some are a bit easier. And I would say one of the biggest causes actually of ring injuries, not the biggest, but one of the biggest, is doctors themselves, not so much nurses. But doctors unfortunately have a tendency to not realize that when patients' hands are hurt, they can swell up, and remove the rings beforehand. So we often are the architects of our own demise. Nurses, I found, are very good when they notice that people have got hand injuries, hand infections, so on and so forth. They tend to remove the rings very quickly. I'm not sure why, but we overlook it. I think it's just a difference in the way our minds work. So, shout out to all our sisters. That's really something that we can learn from them. So, ring removal is something, especially as a junior, that you'll be faced with quite often. And it can be quite daunting because of the amount of edema, the amount of time, like I had mentioned, things like that. And there's simply the possibility that you may injure the patient, or you may not be able to get it off. Patients sometimes put very weird things around their fingers. People have put nuts and bolts and odd-shaped rings, and rings that are made from very hardy materials, such as tungsten and platinum, and which can be quite difficult to remove. So the most common reasons for us to remove is, of course, swelling from trauma, swelling infections, as I had mentioned. Burns are also quite common, and it doesn't necessarily burns off the hand itself. Burns even further up on the limb can definitely lead to swelling, especially if there's a problem with lymph drainage. So as a matter of precaution for the entire team. It's not just the doctors, and it's not just the nurses, it's not even the porters. Anybody who notices a patient with limb injury and notices that they have any sort of ring or tight band or anything around the hand should immediately remove it, because there's always the possibility that it is going to cause a problem later on. So you don't want to have a problem later on when it comes to that. But I will be honest, in my time in the emergency department, the majority of the people have actually put on very hard rings, or forced rings onto their fingers that were not the right fit. And after a few days of swelling, now they realize they can't get it out. And that's normally the reason that they come in. So our goal is to remove it without additional injury, which is sometimes possible, but not always possible. And remember, this applies to fingers and toes, although finger rings are much more common than toe rings. It both can be a problem. And it's very important to use local anesthetic when you are removing the rings, because it can be a very uncomfortable procedure. If it were not uncomfortable, patients would just remove these rings themselves. But it does cause significant amounts of pain for patients. And sometimes you need to manipulate that finger or that toe in a particular way. And that can be quite uncomfortable for a person as well. So we'll just go through the anatomy and physiology of your fingers. So your blood supply is from your digital arteries, all right, from the radial, ulnar, palmar, and dorsal injuries. And your venous return is through the dorsal digital veins. Okay. So all of these sit around the finger, and they tend to be a little bit deeper towards the proximal end and then become a bit shallower towards the distal end, but they are relatively close to the skin in any case. So what happens is, with the rings, the tight ring acts as a tourniquet, and it starts to impede venous return. And this venous return now that's being impacted is what causes your swelling. And eventually, should your swelling get bad enough, you can eventually compromise the arterial blood flow. So the easiest way to check is just to look at the digit. If the digit is still relatively perfused, you can still get a bit of capillary refill, you know that you've got a bit of time. But if the digit is already looking cyanosed, or it's already got skin changes, you don't have much time to work with. And in some cases, you may have to advise your patient that certain sections have already, become necrotic and you're not really able to save them, but you may be able to save most of the digit. Even if you can't save, for example, a fingertip or the distal phalanx, you may still be able to save the rest. And the more of any limb that you save, the easier it is to rehab. So that's one of the things that we've got to look at as well. There's always the risk of skin breakdown, tissue necrosis, infections, and loss of digit viability. And infections and tissue necrosis and skin breakdown are also quite common after removal because of the techniques that we use. Okay. So why do you do it? Like I say, we want to prevent ischemia of the digit, any sort of neurovascular compromise, such as decreased capillary flow, mottling, paleness, paresthesias. These are all bad signs of arterial injury, and that's also another indication. And then pain or potential for edema in injuries or other conditions. So there's no absolute contraindication. And the thing is, it's just a question of what technique you're going to use. So, to give you an example, we'll talk about some of the techniques you use for mild swelling. Now, if you have a patient with a severely swollen digit and is already showing signs of compromise, you're not going to start with the more, with the first techniques. You're going to go to a more advanced technique, as quickly as possible. All right. So this is one of the most common techniques that's used, and this is called the caterpillar technique. Now, the caterpillar technique is relatively successful. And it's very good, especially when you've got an early injury. When you've got an injury where the swelling has just started, it hasn't been entrenched, let's say, for a day or two. My apologies, the son just there in the background. So, or if you've got a softer ring that you can sort of manipulate and that might be a little bit malleable and things like that, the caterpillar technique is actually very, very good to use. But once you've got entrenched edema, you've got a large amount of swelling, and especially when the area distal to the ring is quite swollen, the caterpillar technique can be quite difficult to use. Now, the normal way that you would do it is by slowly moving the ring forward in a caterpillar-like motion. So just as a caterpillar moves one side of the body, then the other, one side of the body, then the other. That's generally how we do it. So as you can see here, as they've described here, you move a bit forward and then you move a little bit forward again, and then you move the bottom forward. And you try and do that, by alternating the pressure on each side. So in the first case, you would probably push down from the top. Sorry, in this case, you'd push from the bottom to increase the space at the top and then push forward and then push down and then push forward. So it is a good technique, and I've used it on a few occasions, and it really does work. There's no issue with using that, especially in the case of mild swellings. One of the problems with the caterpillar technique is actually you as the physician, because normally in order to get to this area, you actually have to use your own fingernails. So whether you are gloved or not, you normally have to insert your own fingernails next to the ring. And if you can imagine, just slowly but surely pull. And on the few times that I've done it, the next day I've woken up with nice little hematomas, lifted nails, things like that. So just something to be wary of, that if it's very tight and if you try this technique, you can also hurt yourself quite a bit. But the nice part about this is it very rarely causes any injury to the patient, and it's very good as a starting off technique, especially if you haven't used it before. But essentially what you're doing is moving one side of the ring, allowing the edema to subside, moving the other side while putting a contralateral pressure as well. So that's the caterpillar technique. And I've read articles like out of Canada and things like where they've actually tried some more advanced versions of this, using sutures to try and bring down the swelling around and then trying to push the ring over the sutures. And they found, there's always newer and newer techniques, but these ones that I've found are the ones that are recognized by the emergency medicine societies of Canada and UK and South Africa. So that's why I've put them in. But by no means are they the only techniques that are available, but I've tried to cover quite a bit. Now, this is the most common, and I would say probably the most commonly used and most successful technique that we find in the emergency department, which is the use of string. And when we say string, we mean suture material, actually. So this is very good, especially when you've got a lot of swelling distal and proximal, or just distal. Proximally, you'd rather, but no swelling distally, you'd rather use the caterpillar technique. So what this does And the one way to do it, and the easier way to do it, is to use an absorbable suture. Generally, if you use a non-absorbable suture, it can cause a bit more damage to the skin, but using a non-absorbable suture is perfectly fine, and it causes less damage to the skin. And using an absorbable suture is fine as well. When we talk about damage, we just mean it tends to excoriate the skin a bit more if you use a non-absorbable suture. So essentially what you do, and as they've put it here, is that you pass your suture underneath. Now, I depending on the tightness, I've had to leave the needle on the suture very often just to be able to get it underneath here. And in some cases, unfortunately, you are going to go through skin. You are going to catch a little bit and then, pull it out from the other side. All right. So once you've got it out, then the thing is, it's really up to you how you would like to start. But the way that I normally start is I actually start distally and slowly but surely start wrapping the suture. Now, of course, you've got to look at the length of your suture. This is obviously a very long suture. If you had a much shorter suture, you may start here. But what you would do is you'd start making concentric rings around the finger. And as you make those concentric rings, you're basically displacing the edema either distally or proximally until eventually your concentric rings get close to the ring, and then you pass the needle underneath. Now, if you've gone in let's say, a clockwise direction, so you've been, let's just draw this. So get a shape here. So let's say you've been pulling the screen. All right, let's do it as they've got it here, yeah, which is clockwise. So you've been moving your suture clockwise to get to this point. Once you get here, you are going to now try and unwind everything. So in other words, by putting force on this piece now that's proximal there, you're going to now start moving your suture back. You're going to start using that as a pulley to try and move it over. The only difference being that now when you are moving in the second time, you're going to now move in the opposite direction. If you move in the same direction, all you're going to do is just keep on tightening it. That's it, nothing else. So you apply traction and counter traction if you need to, and you pull the suture. Now, you must understand that it takes quite a bit of force to actually remove these sutures. So I would suggest using 2O, 1O, or even O, the largest suture that you have available in your emergency department or that you can obtain in your hospital. I would stay away. The only one I would really stay away from is Proline. Proline is normally available in a lot of the bigger theaters. The problem with Proline is it's extremely slippery, so it's very difficult to work with. But any of the other sutures, I mean, if you can get an O nylon or you can get an O absorbable of any kind and actually get it in there, they work brilliantly. Another one that also works very well is the looped nylon that's used for abdominal surgery. The reason being that because it's in a loop, it's basically giving you a double thread, if I can put it that way. And it tends to be much stronger because when you're pulling, it's as though you've got two threads and you're pulling with a double strength. So I've used that one quite a bit and it really does help. The problem with this is it can be time consuming. So for example, by the time you actually get your concentric rings and come here, could easily take you about 5 to 10 minutes. And then to unwind the thing could easily take you another 5 or 10 minutes. And then you may only move it a millimeter or two. So you have to restart the process all over again and keep on doing it and keep on doing it until you move the ring forward. Now, there's a few things that can happen that I found over the years. Number one, you get to this point and no matter how hard you try, you can't move the string. It's caught, it's knotted, something's happened. Now, what some people will do is they'll try and force their way past it. And very often that doesn't work. So what I advise in those cases is clip off whatever you've got here. Just remove a piece from this side and then unwind a little bit and pass a new piece underneath and try again. It just saves you a bit of time. If you are a junior in the department, understand that you will probably get left with this because it's time consuming. It's a bit of backbreaking work. If you're a senior in the department, I hate to say it, but this was something I used to love to give my juniors to do because I really hated doing it. But It's it's something that everybody needs to learn how to do. And when you get it right and when that ring finally pops up, it's a great feeling of accomplishment, you know? And as you're moving the ring, you'll often notice that your compression, your edema starts to go down. You'll even see the limb pink up and things like that. And if you start getting good at it, you can actually bring your time down to about 20, 25 minutes, even for a ring that's very badly stuck. And it works very well with rings that are made from hard material. Um, and but with any material, but those that sometimes we can't move, for example, like some of the tungsten rings and things like that, which are very popular in our area, this works very well for them. The only time you may have a problem is if you've got a ring with a sharp edge or a sharpish edge, because it may sometimes cut through your suture as you're trying to do it. But it is the most popular method, and it is a very good method for doing it. So essentially, what you are doing is that you are trying to bring down the edema by squishing it down with all of that suture material. As I mentioned here, we don't really use tracheal tape that much. Umbilical string can be used, although also not as commonly, but 1O or O of any suture, except for Prolene, I would suggest you can use. So what you do is tight concentric rings to move that edema at least a little bit, get your suture underneath, and then start moving in the opposite direction. And very often it works very well. Now, this is another technique that has been described, which is the rubber band technique. As you can see, it's also indicated for less severe entrapments. I must be honest, I tried this once or twice for more serious rings, and it does not work. Just as an experiment, just to see, you know, what you could do. And really, this is very good also just post-trauma or patient who's got an infection and maybe it's a bit too stuck for the caterpillar technique, but not so severe that you need to go and do the suturing technique as well. So all that you need is a rubber band, lubricant, and a mosquito caliper over there or a mosquito forceps, and you lubricate the finger. You pass the rubber band under the ring and pull distally while moving. That's it. So you're basically just shaking from side to side, and sometimes you have to move around to the other side, and you basically use that. You can also use a bit of rubber piping as indicated here, and you do a similar sort of thing. Although in this one here, you can see they use more of the suture type technique or the string technique, where they're bringing down the edema and then using this piece of rubber to actually get that ring moving. Okay, so let's move on to another one, which is a glove technique. Now, the glove technique is also good for soft tissue injury cases, burns cases. Also, it's good for early swellings where you can still get it out. So the rubber glove is cut to size so that it can fit over the patient's finger. Again, you need lubricant and you need a mosquito clamp. And basically what happens is instead of just sliding like we do with the string and the rubber band, instead of sliding everything under one part, you now basically slide the rubber glove under the entire ring. So you need quite a bit of lubricant and you need your mosquito in order to push that through. Once you've done that and you've got your rubber glove on the other side, theoretically, the rubber glove should move some of the edema, and then you grab the edges of the rubber glove and you start pulling distally. Now, it does work, and if you have got mild swelling, it should come off quite easily. Some of the problems with this is that if it's very tight, your rubber glove tends to break. Sometimes the lubricant makes it difficult to hold on to, so you may have to use swabs or something like that to grab onto it. But if you can get it right, it's very good for these mild ring entrapments. Okay. So what happens if you can't get it out? Now we'll talk about some interesting stuff. So most of us, especially those of us in the public sector, would be quite familiar with this particular piece of machinery here, which is the ring cutter. Now, those who are lucky enough to work in a more resource-rich environment would actually now have the electric or battery-driven ones, but we still have the old style ones. So this is for severe swelling, embedded rings, and for, as we say, abnormal rings, so non-jewelry. Let's put over there. So you do get manual or battery operated ring cutters as this one is. And the manual one just has a turn key. So what happens is essentially you are holding it with one hand. The pressure plate is passed under the ring. and then the blade is then placed. Oh, sorry about that. Let me just get that back. Sorry about that. So it's placed between the ring and the blade, and then you then turn the key to rotate the blade. Now you must have a look at which way you are rotating. So for most of them, it's a clockwise rotation, but in some you have to rotate anti-clockwise. So just make sure. And you try and cut the ring at the thinnest parts, and then you try to use hemostats to pry it open. It you can consider two cuts for a clean removal, but I can tell you, having used this, your hand will be so tired normally after the first cut, that it'll be practically impossible for you to do it a second time. But it is possible; it's not impossible. So most of the time, once we've got a cut in the ring, we just try and pry it apart, allow some of the edema to recede, and then pull it off after that. Now, if you have a battery operated one, of course, it works much faster, and it's able to cut through with a bit more force than you can apply, but it's still dependent on how much pressure you can apply there. But generally, because you're not doing the work of turning at the same time, it does tend to go a bit faster. There are some electric ones that are available, which are plug-in, and then a mobile, like how you'd have your mobile vacuum, and those actually work with a much better disc. These normally have metal discs, and you have some of the newer ones that I've seen during some CPD meetings. It was quite interesting to see that they've actually got one that works on a basis similar to the cutting discs that are used in angle grinders and things like that, but a similar type of makeup, but it's run completely electronically, and it can cut through quite easily. But again, it's quite an expensive piece of equipment, and most people won't keep that. So that's how you would use a ring cutter. Now, there are some other methods, which is the vice grip, especially for rings that are made out of extremely strong material and that are extremely thick. Now, as I had mentioned, tungsten rings are quite in fashion, around the world. And very often, if people don't size their fingers properly, or have an old ring and maybe they've gained weight and things like that, they may find that they now get stuck. So what happens is, in these cases, no matter what type of a ring cutter you've got or anything like that, you actually require heavy duty machinery like an angle grinder or a proper cutting saw to be able to go through and cut that thing off. So I'll give you an example. Like in our hospital, our maintenance guys are extremely good. They know that sometimes we do need their help, and we've sent patients there. We just give the anesthetic. They're more than happy to actually put it in a vice grip and then cut. Of course, you're running the risk of severe tissue injury if the operator doesn't do it properly, and of course, you are subject to liability, because medical legally speaking, you can't actually do that, but it is done in a lot of hospitals, and a lot of the maintenance gentlemen are very good at their job. So it's unlikely that it will happen, but just be aware of that at the back of your mind. So if you get a young 20-year-old, it's his second day on the job, maybe just ask him to call somebody who's got a bit more experience at doing this type of thing. So we've had to cut off quite a few like that. Now, beyond that, if you have the option of an orthopedic hand department, they also have ways of actually removing rings, which actually are not very common. So there are some denuding techniques that they use to try and remove some of the tissue so that they can create space for the ring to move. And unfortunately, in some cases, you end up with a situation where no matter what you've done, this ring is just stuck. And in those cases, you'll often find the hand surgeons, orthopedic surgeons taking over, because you may have to put the patient under general anesthetic to ease their discomfort. Local anesthetic is just not going to cut it, or you have to have a regional anesthesia, and you'd have to bring in much more advanced equipment to be able to cut through. But just to give you an example, so like if you've ever seen people using an electric saw for an amputation, the bone saw that is used is actually not strong enough to get through a tungsten ring, for example. So they really do have to source very, very strong cutting machines to be able to get these things out. Very often, I remember one case, a friend of mine who's an orthopedic surgeon. I remember just anecdotally him telling us about a patient where he had to eventually get a huge lock cutter, these massive ones that you get, and he had to cut it with that. And it caused quite a bit of damage to the patient, but it does happen. Myself, personally, I had quite a bad one a few years ago. A young girl had unfortunately worn a heart-shaped ring that was too small for her, and it got stuck. And the problem was no matter what technique I used, it kept on cutting through the suture very quickly. It just wouldn't allow it to remain because of points and how it was shaped and things like that. And I remember I had to call in for help, and the doctor who came in was very good, and we managed to eventually get somebody out late at night to actually come and cut it from the maintenance department. And luckily she was okay, but she had suffered quite a bit of tissue damage as a result, unfortunately. So now you've managed to get the ring off. What do you do? So after case elevation, just to bring down swelling, non-steroidals, local wound care, and of course tetanus, don't forget that, and specialist consultation for severe cases. So this is the question: who takes over and when do they take over? So it just depends the level of hospital that you are working in. Hands generally are regarded as an orthopedic domain. However, in some smaller hospitals, district to rural hospitals, where you may only have a surgical department and a medical department, surgery then takes over. If you're lucky enough to work in a very resource-rich environment, you may have a hand specialist on staff who'd actually be able to take you through and actually help. But the first point of call is for us to try and remove it in the emergency department to the best of our ability, and then contact the orthopedics or hand surgeons if we note complications, poor refill thereafter, if we suspect neurovascular damage, so on and so forth. And in some cases, no matter what you do, you cannot get it off. You have to get the patient to somebody who can try. So some of the complications you can have, well, I'd say minor injuries, but you can actually have quite severe injuries. We've had, even using the string technique, we've removed quite a bit of skin at the same time, despite our best efforts. You get cuts and bleeding, and of course these can all complicate. Granulomas can form afterwards, and if you're using cutting tools, patients can get burns or direct cuts from those tools as well. So it's quite important to use them properly. So preventive is, of course, proper technique of the tools and frequent reassessment. I must be honest, like I know with us, our equipment, especially the ring cutters, are not checked that frequently. So they tend not to be that sharp, which is a bit of an oversight on our part as well. Now, if you have seen these techniques and you've used them, that's great. If you're not sure, in our protocols on the website, I have got a section dedicated in I think it's the original protocol booklet, or the one from 2020, not the 2023 one that I put out last year, but the 2020 booklet does have a whole section on ring removal as well. So this is just a joke to finish off. And just to give you an example of the worst that could happen. There was a mental health care user in the area, the hospital where I work at Madeni. I remember this being just around the time that COVID was starting, so about 2020, 2019. And the gentleman had applied rings to each of his fingers and had never sought help for it. And by the time he eventually came into hospital, he actually came for a mental health care issue. He didn't come for the rings at all. He had been living homeless, nobody really to look after him, and he had had a psychotic break. And had attacked some people, and so the police brought him in. And when they brought him in, the fingers had basically granulated over the rings themselves. So you could see a bit of ring, but it was essentially as though the ring had been embedded into the finger itself. There was severe swelling, there was necrosis, pieces of flesh had fallen off. And it was really a very horrifying thing to see. And the unfortunate part with him was he couldn't give consent for an amputation. So he had to actually be treated by a psychiatrist, then be determined whether he was still, able to legally give consent, or if consent would have to be given on his behalf. If I remember correctly, this was one of the few cases where it actually went up to beyond the psychiatrist, because the psychiatrist, as far as they were concerned, he was incapable of giving consent despite their treatment. He had fixed delusions, fixed paranoias, very, very, very fixed psychiatric illnesses. And if I remember correctly, it became, a medical legal issue because they had to bring in, experts on ethics, and they had to speak to them at the University of KZN. But eventually it was decided that the hospital could go ahead because he had ongoing damage to the fingers. And they did amputate, and the poor man was left without any fingers, or I think he had one finger left on one hand. So, if you don't remove these rings, there are, of course, severe consequences. But the majority, I mean, that's a real out there case. But the majority of the time, patients will come in, they will have mild swellings. You will be able to get it off with a caterpillar technique, a rubber band technique, rubber glove technique. And beyond that, then you would use the suturing technique. And beyond that, you would look to cutting tools. And even if you don't have cutting tools available, then you'd look to moving the patient to a higher level of care. So I just want to thank those of you who have joined me today, and I hope you enjoyed it. And it's just a nice compared to some of the ECG talks that we have and blood gas talk. It's a bit more of a relaxed topic. Just something to learn. But like I say, if you ever want to go back, the protocols, they are available. And if there are any questions, you're more than welcome to ask at any time. And don't be afraid to ask for senior help if you are stuck with a very stubborn one. But try some of these techniques first, and you'll be surprised that it does work. Okay, so I just want to thank everybody, and hopefully we will meet up again soon. I'll just give an update on the days. I've just got an issue that I've got to sort out, but hopefully one of the days we will be able to have the next session. Okay, thank you very much, everybody. I really appreciate it, and if there's any question, more than welcome to let me know. Thank you.